Here's our roadmap for today. 1. Classification. 2. Management. 3. Key clinical pearls. 4. Classic exam traps. And 5. A quick recall quiz to test your retention.
Section 1. Classification. The anatomical tiers of the stomach.
So, the Japanese Gastric Cancer Association, or JGCA, classifies these regional lymph nodes around the stomach by moving anatomically outward. Let's look at that very first tier, the perigastric lymph nodes, sitting right on the stomach's surface. Think of them in anatomical pairs. Stations 1 and 2 are right at the top, the right and left pericardial nodes. Stations 3 and 4 trace the sides along the lesser and greater curvature, respectively. And finally, down at the pylorus, we've got Station 5, suprapyloric, and Station 6, infrapyloric. Literally, just trace a stomach with your finger, and boom, you've mapped 1 through 6 perfectly. Building outward into the second tier, stations 7 through 12 take us away from the stomach wall itself and onto the major arteries. This is basically your grand tour of the coeliac trunk and its branches. Station 7 runs along the left gastric artery, and 8 goes along the common hepatic. Station 9 sits right at the root, that's the coeliac artery itself. Then 10 and 11 move left towards the spleen, hitting the splenic hilar nodes and the splenic artery. Finally, 12 is situated right in the hepatoduodenal ligament. The key takeaway here, whenever you hear numbers 7 through 12, instantly visualize those major blood vessels.
And finally, we complete our anatomical scaffolding with the third tier. These are the more distant stations, numbered 13 to 16, and they are absolutely crucial for understanding advanced disease spread. Station 13 is tucked right behind the posterior pancreatic head. 14 traces along the superior mesenteric vessels. 15 is associated with the middle colic vessels. And Station 16, those are your deep para-aortic nodes. Grouping them into these distinct tiers, perigastric, arterial, and distant, is going to make recalling all these numbers so much easier.
Moving on to Section 2. Management. Translating anatomy into surgical action.
Okay, so knowing a numbered list is great for passing a multiple choice question, right? But how does this actually translate into surgical action in the operating room? Why do we care so much about perfectly classifying these nodes? Well, it all comes down to lymphadenectomy, the surgical removal of lymph nodes. When a surgeon performs a gastrectomy to remove stomach cancer, they can't just take the stomach. They have to take the associated lymphatic drainage to prevent a recurrence. And the exact extent of the tissue they resect is directly dictated by that Nishi classification we just walked through.
And this brings us to the two main surgical approaches, the D1 versus the D2 lymphadenectomy. A D1 lymphadenectomy is your more conservative approach. It essentially clears out only those first-tier perigastric nodes closest to the stomach. So that's your stations 1 through 6. But a D2 lymphadenectomy, that is much more extensive. It includes all those D1 nodes, plus it clears out the nodes along those major arteries. It literally just builds directly upon that first-tier foundation.
To get specific, if you're scrubbing in for a D2 dissection, you're going after those second-tier stations we just memorized. You're hunting down nodes along the left gastric artery, the common hepatic artery, the root of the celiac artery, the splenic artery, and, depending on the exact operation you're doing, the appropriate splenic hilar nodes. You are meticulously clearing the lymphatic tissue away from these major vessels to make absolutely sure no microscopic cancer cells are left behind.
Now, the crucial point here is this. We don't just cut based on a textbook. The decision between a D1 and a D2 is not arbitrary. The extent of the lymphadenectomy depends on real-world clinical realities. We're talking the exact location of the tumor, the stage of the cancer, whether you're doing a total or subtotal gastrectomy, the prevailing surgical guidelines, and of course, patient factors like age and comorbidities. Basically, the anatomy guides you, but the clinical context decides the actual plan.
Section 3. Key clinical pearls. High-yield anatomical associations.
If you're crammed for time before an exam, pay close attention. These are the rapid-fire associations examiners absolutely love to pull from. Notice how directly these pair up in clinical vignettes. Station 3 is always the lesser curvature, while 4 is the greater curvature. 7 is your left gastric artery, 8 is the common hepatic, and 9 is the coeliac artery. Then rounded out with 12 for the hepatoduodenal ligament. Honestly, drill these pairs. Examiners will often just give you a vessel and ask for the station number, or vice versa.
And then, There's station 16. If you remember literally nothing else from the distant tier, please remember that 16 equals the para-aortic nodes. Involvement here usually signifies widespread advanced disease, and it heavily influences whether a tumor is considered resectable for cure. 16 is para-aortic. Never forget it.
Section 4. Classic exam traps. Don't lose points on these pairs.
Examiners are tricky for sure, but they're also super predictable. They know exactly which numbers students tend to mix up when the pressure's on. Trap number 1, the pyloric nodes. Station 5 is suprapyloric, while station 6 is infrapyloric. In the heat of an exam, it is remarkably easy to flip these two around. Just remember that alphabetically and numerically, they don't perfectly align with top and bottom concepts in a standard way for everyone's brain. So you kind of just have to brute force this rule. 5 is on top, supra, 6 is on the bottom, infra.
Trap number 2 is even more common. Station 10 versus Station 11. Station 10 is the splenic hilum, but Station 11 is along the splenic artery. The sneaky part here is that, anatomically, blood flows through the artery before it hits the hilum, but in this numbering system, the hilum actually gets the lower number, 10, and the artery gets the higher number, 11. Keep that straight, and you're going to secure points that your peers will definitely lose.
Section 5. Quick Recall Quiz. Test your knowledge.
All right, it's time to see if you've been paying attention. We're going to do a quick recall quiz to really cement everything we've just built. Here's the question. A gastric cancer has lymph node metastasis to nodes along the left gastric artery. Which station is this? Take a second. Think back to that second-tier arterial breakdown. The answer is Station 7. If you got that right, fantastic work. You successfully recalled that major arterial tier. If you missed it, hey, no worries at all. Just rewind this explainer a few minutes and review those high-yield pearls again before exam day.
We have covered a lot of ground today, from the pericardial nodes all the way out to the para-aortic stations. But I want to leave you with this final thought. Anatomy guides the hands, but the living patient and the tumor stage dictate the cutting. Memorizing these stations is an absolute requirement for passing your exams, but ultimately, it's about translating these numbers into a safe, effective operation for the patient lying right there on your table. So, when the time comes, will you be ready to make the call? Keep reviewing, keep studying, and I'll see you in the next explainer.